President of our Saharanpur Obs and Gynae Society, and the second speaker we have Anju Jain ma'am from the Varanasi. Dr. Nutan Upadhayay will deliver talk on the high risk pregnancy, and Dr. Anju Jain, she will speak about the anti-scan 11 to 13 week plus 6 week scan. And both the topics are very practical. We are facing day by day practice. We have two chairperson. The first session of the Dr. Nutan Upadhyay is chaired by Dr. Poonam Makhija ma'am, and the second session is chaired by Dr. Seema Agarwal. So I request Dr. Poonam Makhija ma'am kindly proceed forward and read the CV of Dr. Nutan Upadhyay. Poonam ma'am.
Yeah. Good evening, everybody. And thanks, Nanita, for a warm welcome. And it is so good, so good to see you all, to be connected. Especially for me, I'm in home quarantine. So to begin with, the first topic is high-risk pregnancy. And we know that the key to approaching a patient with potential high-risk pregnancy is identification of the risk factors, namely the fetal factors, the maternal factors, which means the medical disorders associated with pregnancy, the obstetrical factors, and the obstetrical complications, and a very vigilant antepartum surveillance. So this topic will be covered by Dr. Nutan Upadhyay. I will be presenting a small introduction of Dr. Nutan. Dr. Nutan Upadhyay is a trained surgeon and consultant in OBS and Gynae. She specializes in laparoscopic surgery and infertility treatment. She is the president of the current year 2020 of Saharanpur OBS and Gynae Society. 2020 is a COVID year, and but thanks to the dynamic president, Dr. Nutan, we have been upgraded and have had all the important and relevant topics and seminars delivered to us on Zoom. She has made us all tech savvy. So she has been the scientific secretary in the year 2003. She has been attending various scientific seminars as a panelist and as an expert consultant. She has presented a paper in RCOG conference in New Delhi on male infertility. And she has presented various papers in the FOXI conference and in the SBI conference. I must add here that Dr. Nutan Upadhyay is not just a keen academician, she is an artist. She's a dancer, she's a poet, and she's on various social forums connected with women health, especially health issues of adolescent girls. So over to Dr. Nutan Upadhyay.
Thank you, Dr. Poonam, for such kind words. First of all, I think Dr. Poonam is a torch holder in our city, and her hospital, Saksham Hospital, has been one of the pillars, I should say, in all healthcare issues, and she has steadfast and been. She herself is a big source of strength for all of us, and she's really an inspiration. And Dr.
Nutan ma'am, there is disturbance. Yeah, मेरी में problem है. मुझे बहुत अच्छी आवाज नहीं आ रही है.
There is some breaking of voice.
Is it now? It's fine now. Should I come here? Is it okay?
It is not clear.
I think this issue is because of the network.
No, I don't think so. आपने अपनी वो जो वॉल्यूम है उसे फोन में कम तो नहीं किया हुआ, उसको देखो आप.
नहीं, I am on the laptop.
अच्छा.
So
अभी थोड़ा सा बेटर हुआ है पहले से, बट थोड़ा सा
better. Try with my phone and see the volume का. Should I connect from that and see? Who is that? Priyanka, Khushbu, can you guide me?
Yeah, ma'am. Anand?
Should I connect through?
of you, and it is so good to be connected on Zoom. And today our topic is high-risk pregnancy, and we all know that the key to approaching a patient, a potential patient of high-risk pregnancy is identification, means identification of the risk factors, which could be fetal factors, which could be maternal factors, which means both medical disorders in pregnancy and obstetrical complications. And of course, a very, very vigilant antepartum surveillance, which would include constant clinical examination, physical examination, and various tests and procedures to identify the high risk. So this is a vast topic which will be covered by a dynamic speaker, Dr. Nutan Upadhayay. I will be presenting a short introduction to Dr. Nutan Upadhayay now. Dr. Nutan Upadhayay is a trained surgeon and consultant in OBS and Gynae, specializing in laparoscopic surgery and infertility treatment. She is the president of Saharanpur OBS and Gynae Society in the current year 2020, which is the COVID year. And I must mention here that despite the COVID, Nutan has been very, very dynamic and has brought to us all the important and relevant talks and seminars on Zoom. She is the one who has made us all tech savvy during this COVID times. So thanks to her, we are today again on such a talk, listening to some useful topics. She has been the scientific secretary of Saharanpur OBS and Gynae Society in the year 2003. She has been attending various scientific seminars as a panelist and an expert consultant. She has presented a paper in RCOG conference in New Delhi on male infertility. She has presented paper in the FOXY and the and the SGI conference. I must add here that Dr. Nutan Upadhayay is just not a keen academician. She is also an excellent artist. She is a dancer. She's a poet. She's involved in various social forums dealing with women health, especially the health issues of adolescent girls. So on to Dr. Nutan Upadhayay. Nutan, we can't hear you at all. बिल्कुल आवाज नहीं आ रही. Can people hear? I am not able to hear Nutan.
Yes, sir. Ananta, have you muted her? No, right?
Maybe ma'am is
issue that's going on. I think we shall not waste any time, and we'll start the talk. We are already running out of time. As we know, our special speaker is Dr. Anju Jain, who is going to speak on the anti-scan 11 to 13 plus 6 weeks. And in keeping with that, we have taken this topic of high-risk pregnancy so that we are able to correlate both of them. Why this anti-scan has become so important in these times. So can I have the next slide, please? Mr. Anand, can you just change that? Yeah. Okay, next, please. Okay. As we know, obstetrics is a unique medical specialty as it deals with two human lives at any given time. There is nothing such as no risk in obstetrics. Pregnancy can either be low risk or high risk. Level of risk can vary in the pregnancy over time. Aim of provision of antenatal care is to ascertain maternal and fetal well-being as well as undertake surveillance to detect those mothers and fetuses that may be at risk of adverse obstetric outcome. Determination of risk is vital to ensure timely action to minimize perinatal morbidity and mortality. Risk stratification is also important from administration point of view to achieve optimum utilization of available healthcare resources. So the key point is that every obstetric patient is at risk. She may be at low risk or a high risk. That is a different issue. Can I have the next slide, please? Pregnancy is and should be considered a unique physiological normal episode in women's life. However, pre-existing disease or unexpected illness of mother or fetus can complicate the pregnancy. Risk is defined as the probability of an adverse outcome or a factor that increases this probability. A pregnancy is defined as high risk when the probability of an adverse outcome for the mother or child is increased over and above the baseline risk of that outcome among the general pregnant population by the presence of one or more ascertainable risk factors or indicators. The classification does not take into consideration the magnitude of the risk or the importance of risk to the health outcome of the pregnant population at large. Next slide, please. So this classification is by various agencies. Here they have mentioned the Eunice Kennedy Shriver National Institute of Child Health and Human Development. This institute's classification. A high-risk pregnancy is one that threatens the health or life of the mother or fetus. In a high-risk pregnancy, the mother, fetus, or neonate is at increased risk of morbidity or mortality before or after delivery. Next slide, please. In clinical practice, there can be two situations. A high-risk pregnant woman patient comes to obstetrician with a poor obstetrical history or well-recognized medical complications. In such situations, planning for antenatal to postnatal care is to be done. Majority of high-risk pregnant patients seen in daily practice, however, are women who in course of otherwise normal pregnancy develop unexpected complications. These patients with unexpected complications frequently require difficult management decisions. In situation of suboptimal outcome, inherent legal issues are being faced by the obstetricians. Next slide, please. Identification of high-risk pregnancy. Several high-risk identification systems have been developed by many professional bodies. Each scheme consists of a list of conditions known to be compromised prognostic indicator in pregnancy. Medical complications affecting mother and bad obstetrical history are few important catch points for identification and scoring of high-risk pregnancy. Most of these systems give different numerical values to the high-risk factors depending on severity of their effect on pregnancy. Cumulating of numerical score is supposed to reflect the seriousness of the potential problem. Next, please. Can you please change the next slide? Ananta, can you please change the next slide? It's stuck. Can you please change the next slide? हाँ नहीं डिस्कनेक्टेड हो गया. शाहू पार्थ, आप मेरे को कनेक्ट कर दोगे क्या बेटा? आपके में बहुत अच्छे से हो गया था। And that is bad obstetrical history, recurrent pregnancy loss, prematurity and PROM, RH disease incompatibility, diabetes, multiple pregnancies, fetal anomalies, and assisted conception, which is now a leading cause of our concern. Can you just change the next slide, please? Complications which may develop during pregnancy, obviously placenta previa and IUGR, fetal growth restriction, which is now an increasing challenge. Any critical emergency that can develop, fulminating preeclampsia, eclampsia, massive obstetric hemorrhage, coagulopathy, amniotic fluid embolism, severe sepsis, any other life-threatening condition. Next slide. So this is a Coupland scoring system. They have put a number to each of the risk factors, and then they get a scoring system. Number of institutes have this high risk evaluation form, which is filled at the time of admission, so that they can segregate the patients in high risk or low risk group. If supposing it's a patient, there's a patient who is in the labor room and he is in the high risk group, that patient will have to follow different protocols. This is the aim of the scoring system. Can you please change the next slide? Significance of this scoring is that advantage of scoring system for high risk pregnancy incorporation into antenatal care is that it documents the effort made to identify and analyze high risk factors. So the main emphasis is now that we start analyzing and categorizing a patient right from their first antenatal visit, that whether this patient comes under a high risk category or is a low risk category. Any risk that we identify as high risk, so we are categorizing that patient at the first visit itself. It helps the obstetrician to identify planned referral or multidisciplinary consultations, as well elaborate the prognosis for pregnancy outcome. The pregnancy outcome can be optimized by medical intervention. Next slide, please. So the HRP categorization, high risk pregnancy categorization, high risk mother with a high risk infant. This can be one scenario in which, supposing there is a severe hypertension or IUGR, high risk mother with low risk infant, maternal asthma or history of venous thromboembolism, low risk mother with high risk infant, just like a normal pregnant woman, and the fetus is exceptionally compromised. Low risk mother and low risk fetus who is at a risk of developing any complication during pregnancy. This is a useful template that we can keep it in our OPDs and follow accordingly, with limitation of predicting all adverse outcomes. Obviously, all adverse outcomes can't be predicted, but yes, in a busy OPDs, these help you in categorizing the patients. Next slide, please. So as we know, this was the initial pyramid which traditionally was being followed, in which in first trimester there were limited antenatal visits. Slowly the visits went on increasing till the last trimester, and when the patients were encouraged to come at a for frequent visits, because it was believed that most obstetric complications occur in third trimester. Most adverse obstetric outcomes are unpredictable during first and second trimester. This was the belief. Next slide, please. But this traditional belief has been changed, and now we are in this inverted pyramid scenario, in this inversion pyramid antenatal care, in which advancement in aesthetic care, more assessment and intervention can be done in early gestation as early as 11 to 13 weeks with precision. Traditional pyramid care should be inverted with main emphasis placed first trimester rather than third trimester. So as we know that this is what is being stressed in all the antenatal webinars, that the care of pyramid has to be inverted, and the patient, when initially comes to the doctor, the earlier that we catch the high risk patients, the better are the outcomes going to be. Next slide, please. What is the implication of paradigm change in antenatal care? Risk stratification into low and high risk, as I have mentioned, and better utilization of our resources, and better prediction, that we are able to follow the high risk patients more closely. Please, next slide. In India, about 20 to 30% pregnancies belong to the high risk category, which is responsible for 75% of perinatal morbidity and mortality. So as we know, almost 1/3 of our patients antenatal patients all come under the high risk category, more so because of their poor perinatal outcomes. So to increase our perinatal live ratios and to improve the perinatal outcomes, we have to follow the inverted pyramid, the care that has been now advised. Every year, nearly 5,29,000 women die globally due to pregnancy-related causes. So, pregnancy and its related causes still are the major health issues in young women of globally. Next slide, please. So, what is our role? What is our role in this, and what are the preventive steps that we can take right from the beginning, so that high risk patients become low risk, and what are the nutritionally relevant advices that we can give our patients in our antenatal clinics? Thought is much before creation. So that is what is emphasized, that not the preconception clinics or the advocacy for preconception counseling as now gaining ground. Next slide, please. Nutrition may be defined as the science of food and its relationship to health. Dietetics is a practical application of principle of nutrition. Good nutrition means maintaining a nutritional status that enables us to grow well and enjoy good health. This is, I think, well known to all of us. Next slide, please. Pregnancy is a special situation. Pregnancy is the time of rapid and profound physiological changes from the time of conception until birth. Nutritional requirements increase during pregnancy to maintain maternal metabolism and tissue accretion while supporting fetal growth and development. Poor dietary intake or deficiency in key macro and micronutrients can therefore have substantial impact on pregnancy outcome and neonatal health. Although a healthy and varied diet remains the preferred means of meeting nutritional requirements, some nutritional needs in pregnancy are challenging to meet with diet alone. Next, please. Pregnancy, physiological or pathological state. Pregnancy is associated with physiological changes that result in increased plasma volume and red blood cells and decreased concentration of circulating nutrient, binding protein, and micronutrient. In developing countries, these physiological changes in pregnancy can be aggravated by undernutrition, leading to micronutrient deficiency status such as anemia and vitamin deficiency. Around 30 to 50% of pregnant women worldwide suffer from some vitamin deficiency. The deficiency can have adverse consequences for both mother and newborn infant. Next slide, please. Fetal origin of adult disease. This is also being highlighted a lot. It is now widely accepted that risks of a number of chronic diseases in adulthood, such as diabetes, mellitus, hypertension, and coronary heart disease, may have their origins before birth. As it has already been mentioned, now that just like in PCOD, now that it's become an open discussion that these PCOD girls, their origin may have been in utero, in the mother's womb itself. Next slide, please. Nutrition in preconception care. At the time of conception, maternal nutrition is an important determinant of embryonic and fetal growth. Placental fetal growth is most vulnerable to maternal nutrition during pre-implantation period and period of rapid placental development. Most organogenesis occurs from 3 to 7 weeks of missed period. It is the first few weeks of pregnancy, typically before pregnancy is confirmed. It highly signifies value of balance and good nutritional status in preconception care. Next, please. So common pathologies for BOH are hyperhomocystinemia, that this is MTHFR, methyl tetrahydrofluoride reductase enzyme polymorphism, deficiency of water-soluble vitamins, deficiency of fat-soluble vitamins, and deficiency of minerals. I'll just touch on these things, and so that we can know that how these things can be used and enhanced in good perinatal outcome. Next slide, please. This is something that is again gaining a lot of importance. That is hyperhomocystinemia, risk factor in adverse pregnancy or complications. Next slide, please. Basically, I'll just highlight in this slide that homocysteine is an intermediate product in the metabolism of the essential amino acid methionine. That is that in the amino acid metabolism, this is an intermediate product. Any deficiency or defect in its utilization leads to its excess, and this is what is hyperhomocystinemia. And hyperhomocystinemia has been directly correlated with vascular pregnancy complications like early pregnancy loss, placental abruptio, and preeclampsia. Next slide, please. Cause and effect, as I've said, that there are some women who are vulnerable because of the genetic factors. There may be a mutation in the MTHFR genes, and there is another gene, cystathione B synthase gene. So there may be some defect in these genes. Because of this, homocysteine may be underutilized, or other environmental factors just as diet poor in folates, vitamin B12, especially with other vitamin deficiencies. Hyperhomocystinemia is a risk factor for recurrent pregnancy loss. Hyperhomocystinemia has been found to be associated with an approximately 2 to 3-fold increased risk for PIH, abruptio, and IUGR. Abnormal fetal outcome as IUGR, sudden fetal demise have also been associated with hyperhomocystinemia. Next slide, please. So the maternal complications, as mentioned, preeclampsia, placental abruption, heart disease, damage to blood and organ systems. Next slide, please. And the related fetal complications are IUGR, which is very commonly seen in, especially in our areas, NTD, again commonly a common presentation, and other congenital defects. Next slide, please. Epidemiological studies showed that BOH attributes to 20% of high-risk pregnancies, and so this is something that can be controlled, can be altered. So the risk, so the emphasis now on catching them at the earliest visit, antenatal visit. Next slide, please. Folate deficiency again during pregnancy associated with neural tube defects. It helps in reduction of high level of homocysteine. High homocysteine levels, as mentioned, is leading to maternal and fetal complications. Next slide, please. Folic acid in preconception period, we are well aware of it, and there are various recommendations. Some say 400 micrograms, some say there are different recommendations, but the bottom line is that folic acid acid supplementation in the preconception period is a good way to start a well-planned pregnancy. Next slide, please. L-methylfolate, there's a lot of talk on the active form of folic acid. Why it is being advocated? Because folic acid may not be well utilized by every patient, L-methyl folate is already broken for those who lack the ability to break down folic acid on their own. It affects the distribution of folate and maintain a delicate balance between folate for nucleotide synthesis and those for methionine synthesis. That is, again, folic acid along with homocysteine plays an important role in the amino acid chain of events, and so there are lots of people who are not able to convert this folic acid into its active form, that is L-methyl folate. So that is why the active form of L-methyl folate is now being advocated, that yes, we should give the active form of the folic acid in the folic acid supplementation, both preconceptually and in the antenatal period. Next slide, please. So L-methyl folate is superior in reducing homocysteine levels because it's easily available as compared to the folic acid. Next slide, please. So as we have, I wanted to highlight is in this slide is that MTHFR genetic polymorphism. There is a condition like this in which even after giving folic acid supplementation, there may be a group of patients who are still folic acid deficiency because they are not able to convert it into the active form, that is the L-methyl folate. Next slide, please. Again, so this is more effective than folic acid. Unmetabolized folic acid in plasma appear regularly after folic acid supplementation, but rarely after 5-MTHF supplementation. Next slide, please. So the conclusion is that the use of 5-methyl tetrahydrofluoride to replace folic acid in treating MTHFR reduces potential of masking hematological symptoms of vitamin B12 deficiency, reduces interaction with medication inhibiting dihydrofluoride reductase, prevents formation of an unmetabolized folic acid in blood circulation, overcomes metabolic defect caused by this polymorphism. Next slide, please. So there is also the role of multiple micronutrient supplementation in BOH. We'll just run through them. Next slide, please. B complex, we all know, along with B12, it is again acts in this amino acid sequence of events. Next slide, please. So there are multiple B complex deficiencies which can enhance already existing issues of folic acid metabolism. Next slide, please. Again, B6 and B12. Recently, role of multivitamin supplementation along with folate in improving pregnancy outcome has been studied. Vitamin B12 status alone may influence NTD risk independent of folate status. Even if the folic acid supplementation is adequate, if vitamin B12 status is not good, again there may be a risk of NTD. Next slide, please. And needless to say, there is a strong correlation that has been found between them and even preterm labor, cases of premature labor and PROM. So again, vitamin C and vitamin E, these are antioxidants which again help in this chain of events. We already know vitamin C supplementation. It's a water soluble, you can give it freely, but there is a caution with the vitamin E supplementation which has to be given for a limited period. Next slide, please. Vitamin A, again, it has number of actions, especially the antioxidant, and its other functions include vision, growth, bone, metabolism, immune function, gene transcription, and antioxidant activities. Again, there's a word of caution, it has to be given for a limited period during pregnancy. Next slide, please. Again, this as I've already mentioned, for a limited period. Next slide, please. Vitamin D, this is again in a highlight both in pregnant and unpregnant patients. There are lots of studies showing that vitamin D deficiency itself has a major role in BOH, bad obstetric history, and maternal vitamin D deficiency has been associated with neonatal rickets as well multiple adverse pregnancy outcomes, including gestational diabetes, preeclampsia, preterm birth, and low birth weight babies. Fetal lung development and neonatal immune conditions such as asthma may relate in part to Maternal vitamin D supplementation. Preventing and treating vitamin D deficiency in pregnancy is important for optimizing maternal fetal bone health. So there's a continuous but low requirement of vitamin D all throughout the pregnancy period. Next slide, please. So I think this in a nutshell, multivitamin supplement with folic acid have protective effect on neural tube defects, CV defect, limb and orofacial defect. Next slide, please. There is a strong recommendation that all women of reproductive age should be encouraged to take a folic acid containing multivitamin supplement for purpose of supporting healthy pregnancy outcome and prevent congenital anomalies. Next slide, please. Again, minerals and trace elements, just a word about them. Next slide, please. Anemia, it's a big magnitude in our country, but so this is something that is, I think we are dealing with daily, and we are well averse with the magnitude of anemia in India and how it has to be dealt with. Next slide, please. I'll just put a word that daily 60 to 100 milligram of iron with 500 microgram of folic acid for all non-anemic pregnant women at first antenatal visit is recommended by the FOXI for primary prevention of anemia. Repeat hemoglobin percent at least once in each trimester. Oral iron compound choice should be individualized. In pregnant women with established mild to moderate anemia with gestation period less than 30 to 32 weeks, oral iron treatment, and if there is a higher period of gestation, we may have to go to the injectable ones. Iron therapy should be continued till iron stores are replenished, usually till 3 months after hemoglobin becomes normal. Next slide, please. Severe nutritional deprivation studies show periconception, decreased fertility, increased neural tube defects, first trimester increased stillbirth, early newborn deaths, second and third trimester low birth weight babies, small for gestational age, preterm birth. Birth weight significantly influenced by starvation, obviously by dietary deficiencies. Next slide. So I think all these have been discussed. Next slide, please. Then micronutrients and their role. Next slide, please. There are again role of micro nutrients and the minerals, just like copper, selenium, magnesium. A good balanced diet should take care of these requirements. Next slide, please. Again, trace elements. Again, a good balanced diet can take care of these requirements. Next slide, please. Iodine deficiency, which is a big role. It has a big role in especially in our belt. So we are well aware of it. Recommended iodine allowance in pregnancy and lactation is 220 microgram. In regions where only 20 to 90% household used iodized salt, preconceptional supplementation with 150 to 250 microgram add to improve obstetric outcome. Next slide, please. The trace elements have already been mentioned. Copper, selenium, chromium, and manganese are trace metals which all have important roles in certain enzyme function. In general, most can be provided by an average diet and usually routine supplementation not required. Next slide, please. High-risk pregnancy can affect both mothers and child's health. Bad obstetric history is one of the major reasons for high-risk pregnancy. It can be sometimes morbid or mortal. It includes conditions like BOH, IUGR, PIH, miscarriage, preterm birth, hypothyroidism. Pregnancy is a condition of high demand nutrition. Multiple micronutrients should be supplemented from preconception till delivery for positive pregnancy outcomes. Next. Next slide, please. Balance is the key. Nature obviously is a generous giver. Human-made situations as well as socio-economic, geographical, cultural situations make availability of essential nutrients difficult and sometimes impossible. Unprecedented situation of lockdown and COVID-19 has put before us a great medical economic challenge. Next slide, please. Next slide, please. The test of any civilization is the measure of consideration The test of any nutritional deficiencies during pregnancy remains a public health concern. The test of any civilization is the measure of consideration and care which it gives to weaker and vulnerable members. I hope I was audible, Dr. Poonam. I end my talk, and can you please unmute Dr. Poonam? Ananta?
I think I am audible.
Yeah, now you are. Yeah.
Yes, Dr. Poonam, you are audible enough.
Finally?
Yeah, you were audible. You were quite clear. Yeah.
Okay. So I think with this we end our first talk. Dr. Poonam, I have a suggestion. Can we keep discussion at the end of the second talk?
Yeah, I think we should do that.
Yeah,
in the end, we can have
so can we invite Dr. Seema ma'am to
Yeah.
chair our next talk? Dr. Seema ma'am, are you there?
बार-बार अंदर बाहर मत करियो, पहले दरवाजा खुलता दिखता है.
Dr. Seema Agarwal, is she there? Ananta, can you check please?
If I may say so, I think some people are not
Ananta, just unmute Dr. Seema and Dr. Anju and mute everybody else, please.
Hello. I am here. Am I audible?
Yes, ma'am, you are audible. Yes.
Okay.
Mute everybody else now,
So
and let Dr. Seema and Dr. Anju.
hello. Greetings from Saharanpur Obstetric and Gynae Society, and I welcome everyone who has logged in late for today's webinar. Dr. Nutan, you have very nicely given an overview of high-risk pregnancy, and I especially like the inverted pyramid in your talk. And more importantly, your talk is a good preface to the next talk, which is going to be delivered by the learned speaker. Every pregnancy is a precious pregnancy. No doubt, obstetric practice is becoming a challenge. Thankfully, with advancements in scientific knowledge, diagnostic gadgets, and sonography, we are able to pick up these high-risk patients in time. The role of sonography is increasing day by day, and we are able to pick up patients very early in pregnancy with advanced technique and advanced skill of the person who is doing the ultrasonography. Today, the first early pregnancy scan, especially the anti-scan, the topic is being covered by a senior endoscopic gynecologist from Varanasi. She is a renowned gynecologist for her skills in laparoscopy, hysteroscopy, colposcopy, infertility management, and obstetrical ultrasound, especially the anomaly scan. A gold medalist from Delhi University, she is the director of Jain Hospital at Varanasi. I welcome you, Dr. Anju Jain, in today's webinar, and I invite you for your talk for the audience. Welcome.
Thank you, Dr. Seema, for the kind words. And I bring greetings from Varanasi, a holy city of Varanasi, and in this holy month of Sawan. Can I share my screen? Khushbu, can I share my screen?
Yeah, ma'am, you can share. Hello.
But I don't see the share option here. This the previous presentation. Yeah, now it is there. Yes, I'll do that. Is it visible on the screen?
Ma'am, you need to select the screen below the enter.
Enter. Okay. No.
Below the entire screen, you need to select that window and just click on share button.
I've already clicked on the share button. By 10 weeks, which is there, then renal development is not complete before 12 weeks. So we cannot comment upon whether the kidneys are there or not there before 12 weeks. Then urine production, it starts by 11 weeks. So we need to wait till 11 weeks to comment upon these anomalies. Then why 13 weeks 6 days is taken as an upper limit? Because as the period of gestation advances, fetus acquires a vertical orientation, so we cannot acquire a horizontal mid-sagittal section to measure NT. Then lymphatic system develops, so the pathological nuchal translucency which was there by 13 weeks will reduce and we will miss the chance. Then if we diagnose any anomaly in first trimester, we can offer the advantage of termination in first trimester itself, causing less psychological and physiological trauma to the mother. So first image we acquire for 11 to 13 week 6 day scan, everybody knows we have to measure the CRL because NT is corresponds to the CRL measurement. So we acquire a true sagittal image of the fetus. True sagittal image, by that I mean that we should see the nasal bone, the skin, the nasal bone, palate, no zygoma in between. we see the midbrain, we see nuchal translucency, and once we acquire this image, we measure the CRL maximum diameter from the head to the rump. There is lot many information which we can gather at this image only. Not only the CRL, we can look at the facial profile of the fetus. If there is an obvious frontal bossing, if there is retrognathia, the chin is moved backward, if the anterior abdominal wall is intact or not, we can see the bladder. If there is an obvious bladder enlargement, we should measure it in the longitudinal plane. If it is more than 7 millimeter, there is a megacystis, then we look for it then. So once we have acquired the CRL image, then we zoom the head and the upper thorax to measure nuchal translucency. What is nuchal translucency? It is accumulation of fluid behind the nape of the neck. Why it is accumulated? I've already told, because there is immature lymphatic circulation, which result in reduced resorption of the fluid, and there is increased placental resistance, which results in nuchal translucency, and which we measure while doing the scan. And if there is a pathological accumulation, this will be increased, and which acts to as a screening factor. So for this, we need to have a 75% magnification, horizontal position of the head. It should be in neutral position, means there should be an anechoic area between the chin and the skin of the upper thorax. It should be a true mid-sagittal plane. We measure the maximum translucency, and skin should be clear from the amnion. How do we know about that? We can ask the woman to cough, we can tap of the abdomen, fetus will move, and we can see skin away from the amnion. So physiology I've already told. So anything abnormal with the physiology will result in increased NT, like cardiac defects or dysfunction, or if there is a venous congestion in head and neck, if there is a mediastinal tumor, if the chest is abnormally small, as in cases of skeletal dysplasias, if there is an altered composition of extracellular matrix, which is the reason for increased NT in aneuploidies, because the genes code for the proteins. If there are abnormal proteins, there will be altered composition of extracellular matrix. If there is failure of lymphatics and drainage, which later appears as cystic hygroma, sometimes in teen, which is Nunan syndromes, in fetal anemia, in hypoproteinemia, in fetal infections. So these are the common causes of increased NT which we come across: trisomy 21, trisomy 18, 13, Turner syndrome. These are would be the aneuploidies, but it is also associated in congenital heart defect, as I told, skeletal dysplasias in various syndromes. So once we have seen that the NT is increased, what should we do next? Should we ask the woman for termination? No, never. So we have to confirm our it is a screening method. We have to find out the cause for increased NT. We can do it by advising an invasive procedure. We can ask her to go for a combined screening, or we should ask her to go for a non-invasive prenatal screening, or nothing to be advised to her. By simply seeing the increase in NT, we cannot answer all these things. We have to take the history of the woman, her history of any congenital malformation, chromosomal defects in the siblings, her obstetric history, any previous past bad obstetric history, like any congenital abnormal baby she had delivered or she had aborted, or any chromosomally defected baby she has aborted, any abnormality has been detected in the abortus or the baby. And then if she had herself had a heart disease, then we do a judicial counseling and advice. If there has been a history of preeclampsia or preterm labor previously, if there is any history of congenital malformation in the uterus, then accordingly we advise. If she is a low risk woman, primi gravida, 22 years, nothing, only increased NT, we have seen no other markers are seen, anatomic survey is normal, then we can ask her to go for a combined screening or NIPS. She can, but these again are screening methods, not the diagnostic method. If she wants to go for diagnostic method, definitely invasive would be an answer. So why do we care so much about NT? There has been a prospective cohort study of fetal nuchal translucency in first trimester and the pregnancy outcome done by Chinese, and it has shown that the healthy survival rate of fetus with isolated NT was significantly higher than those with structural abnormalities. This proves that we should not be terminating the pregnancies just on the basis of increased NT. Isolated NT has a very good healthy survival rate, and the percentage of aneuploidies in fetuses with isolated increased NT was significantly lower than those with structural abnormalities. Then a woman would be interested to know that what would be the outcome of the baby. Increase NT and the risk of neurodevelopmental disorder, as published in Ultrasound Obstetrics Gynecology in 2017 by Dr. Helmuth and Tabor, concluded that if the NT was first trimester NT was between 95th to 99th centile, there was no increased risk of neurodevelopmental disorders. But if the NT was more than 99th centile, then there was an increased risk of intellectual disability and autistic spectrum disorder. But again, this risk was reassuringly low, less than 1%. And then why do we do an anatomic survey at this stage of time? A systematic review of first trimester ultrasound screening for detection of fetal structure anomalies and factors that affect screening performances done by Dr. Karim and Dr. Aris Paparjaw concluded that detection rate of first trimester fetal anomalies ranged from 32% in low risk group to more than 60% in high-risk group, demonstrating that first trimester ultrasound has the potential to identify a large proportion of fetuses affected with structural anomalies. But the use of a standardized anatomic protocol improves the sensitivity of first trimester ultrasound screening for all anomalies and major anomalies in population of varying risk. So, after assessing the nuchal translucency, we should assess for the nasal bone. It is an independent variable. Presence of nasal bone reduces the aneuploidy risk by 3%. Absent nasal bone or a hypoplastic nasal bone after 12 weeks increases the risk of aneuploidies. It occurs in 67 to 73% of trisomy 21, increasing likelihood ratio of 48 times. But one should remember that it can occur in 1.5% of a normal euploid population. So how do we say that the nasal bone is absent? The nasal bone, it should be either it is absent or it is hypoechoic, less echogenic than the echogenicity of the skin. Ideally, we should see the nasal tip and two equal signs like this, and with the upper line representing the skin and the lower line representing the nasal bone. People would ask that should we measure the nasal bone? By FMF, Dr. Nicholas, he doesn't say that it is required to measure the nasal bone if only the absence or hypoplastic nasal bone is sufficient to act as a variable for aneuploidy. Then we should look for the Doppler of ductus venosus. It is an independent variable and it is associated with increased risk for chromosomal abnormalities, cardiac defect, and later in pregnancy for fetal death. If this is the normal waveform of the ductus venosus, we should be seeing no A wave on the opposite direction. A reversal of A wave is associated with increased risk of chromosomal abnormality. But nowadays, not only the reversal of A wave, if there is an increased pulsatility index more than 1.5 multiples of medium, that is also significant, and it is a risk factor for fetal death later in pregnancy. However, in about 80% of the cases with reverse A wave, the pregnancy outcome is normal. Then we should look for the tricuspid flow, the flow across the tricuspid valve, and any regurgitant flow more than 60 centimeter per second with more than half of the cycle is taken as a positive regurgitant flow, and it is associated with cardiac anomalies and it acts as a soft marker for Down syndrome. However, it may be present in normal individuals. So if we look for all the 4 parameters and then we assess the risk, we can put a put all these parameters in the FMF scoring system, and we can get the score. The sensitivity of using all the 4 parameters increases to 95% with false positive rate of less than 5%. Then again, we all are looking for the fetal heart first of all, and we know that in trisomy 21, fetal heart rate is mildly increased and is above 95th centile in 15% of the cases, whereas it is in trisomy 18, the heart rate is mildly decreased and is below 5th centile in 15% of the cases. But in trisomy 13, it is markedly increased and is above 95th centile in 85% of the cases. So once we are through the NT-NB scan, our ultrasound scan shouldn't stop here. We have to give more time to the mother and the fetus to put an effort to detect for structural anomalies in first trimester, though this scan is not a replacement for a second trimester anomaly scan. Why do we do this? Because a multi-centered Indian study at ACFM Delhi, MEMU Kolhapur, BFMC Bangalore, conducted on 12,000 pregnant women, it proved that at almost 54% of the major defects could be picked up at 11 to 13 weeks scan. Rest 37% were picked up in 18 to 23 weeks scan, and only 1.9 to 2% picked up after second trimester. And a study conducted in King's College London by Nicholas et al. Over 45,000 pregnant women were enrolled, and fetal abnormalities were detected in 488 pregnancies, which and it proved that 43% of these were detected at 11 to 13 week scan, concluding that some abnormalities can always be picked up during first trimester, though some can never be picked up, and others are potentially picked up depending upon the association with increased NT, expression of abnormalities with gestation, and what was the objective of the scan. And talking about congenital heart disease in first trimester, like diseases like double outlet right ventricle hypoplastic left heart syndrome, TGA, AVST, coarctation of aorta, TOF, they could almost 29% of these anomalies could be picked up in first trimester. Though anomalies like VSD, abstines, aortic stenosis, pulmonary stenosis, tumors were not picked up, and so we divide these anomalies into 3 categories: always detectable, sometime detectable, not detectable. Our focus should be on these always detectable anomalies at 11 to 13 weeks 6-day scan, and we should not be missing out on these anomalies like acrania, absent of cranial wall, encephalocele, A-lobar holoprosencephaly, exomphalos, gastroschiasis, megacystis, body stock anomalies, or any missing limb. But at the same time, we can put more effort if potentially detectable anomalies, if we could look at it, like diaphragmatic hernia. If you are seeing stomach and heart at the same level, it points about towards diaphragmatic hernia, though difficult in first trimester. Lethal skeletal dysplasias, if we are in a habit of measuring all the long bones, and if they are less than 3rd or 5th centile, then that may point toward lethal skeletal dysplasia. Isolated bone shortening, if we count the digits, which is practically simple in first trimester, we can comment upon polydactyly, facial cleft, I will show you in subsequent slides, and open spina bifida. Now there are so many indirect signs which we can easily pick up in first trimester, which points towards open spina bifida, and if those indirect signs are present, we can search for open spina bifida. But these anomalies, they are usually not detectable because these organs, they are still in the process of formation, like agenesis of corpus callosum. Corpus callosum is still not formed, so we cannot pick it up. Semi-lobar holoprosencephaly, cerebellar abnormalities, CCAM, pulmonary sequestrations, bowel obstruction, severe hydronephrosis, they are not picked up in first trimester. So once we are taking this image while measuring the CRL, I told you we can look at the facial profile. We see the calvarium. if we cannot see the head, it may point towards acrania, though it is difficult to comment upon in this mid-sagittal plane. Then like anencephaly, if the fetus in a persistent hyperextended position with abnormal spine, it may point towards anencephaly. Then if the abdominal wall is defective, we can see if we are seeing the herniation of bowel, exomphalos and gastroschiasis. Then bladder, I showed that if we see a large bladder, if it is more than 7 millimeter megacystis, if any limb is missing, then body stock anomalies. So for any anatomic assessment, we should follow any specific guidelines, so that not to miss out on these anomalies. Like this is the one I have shown here is an ISWA guidelines. You can follow an American guidelines or a German guidelines, and you can make your own checklist so that not to miss out on those structures. So we go for anatomic survey from head to toe. We don't stop at the mid-sagittal plane. We evaluate the head in the axial plane. We have to measure the BPD. Once we are in a habit of measuring the BPD, we will not miss out cranial vault anomalies. We will not miss out any encephalocele. We will see the butterfly shaped choroid plexus. We will see the midline falx. If the midline falx is absent, there is communication of lateral ventricle, A lobar holoprosencephaly, we can pick it up. Then if we are seeing the third ventricle between the thalamus, we try to always see the aqueduct of Sylvius. Believe me, it is not difficult. We should develop the practice of seeing it. I will show you the video I have taken today itself. Aqueduct Sylvius, we try to focus it, and if we see that aqueduct of Sylvius is abutting towards the occipital bone, this is known as a crash sign. This picture is normal, but if we see aqueduct Sylvius abutting the occipital bone, this points towards an open neural tube defect. Then we see the fourth ventricle, the cisterna magna. Then I purposely didn't talk about intracranial translucency previously, but while measuring the NT, one should look at the intracranial translucency, which is the fourth ventricle with its choroid plexus. If there is an obliteration of intracranial translucency, it is again an indirect sign of open neural tube defect. And simple eyeballing, we can see this. And if we can measure the brainstem to brainstem occipital bone ratio, brainstem and then brainstem to occipital bone ratio. In open neural tube defect, brainstem will increase, IT will decrease, so this ratio will increase. And there is, I told you, this is the thalamus and the midbrain. If it's an open neural tube defect, the whole complex will shift downwards. So by eyeballing, by looking at it, if it is an obvious, we can pick it up at first trimester only. So now we should see the fetus, lung, thorax and abdomen in the axial plane, see the stomach, see the heart, see that they are at the both at the same side, see two inflow tracts, two outflow tracts, always in a habit of using the color flow map, red towards the probe, blue away from the probe. So you'll see two inflow tracts as red and outflow tracts as blue. And see the stomach, put either spine on the 3 o'clock or 9 o'clock position. See the stomach, umbilical vein and portal vein, they always curve away from the stomach. See for the cord insertion. This will rule out omphalocele or gastroschiasis. In omphalocele, the cord will be attached over the sac, covering the herniated gut. In gastroschiasis, the herniated gut will not be covered by the membrane, they will be by the side of the umbilical cord. Look for the bladder, two umbilical arteries by side, so single umbilical artery can be ruled out. Then always see the limbs, all the three segments, humerus, radius, ulna, all the digits, femur, tibia, fibula and the foot. Angle between the foot and the lower limb will rule out, if it is 90 degree, will rule out club foot. See the digits. Then evaluation of uterus and adnexa for pathologies must be seen. Then I'll just show you this video running. Ananda, can you run this video? Okay. If it is not running, I'll show you. This is today only I have taken this scan.
Running, ma'am.
It was running? No. So we can see the maxilla. If there is a gap in the maxilla, more than 1.5 millimeter, it will suggest cleft palate. And you see this palate is not a single line. There is another line above this lower line. If we see only one line like this, that may be an indication of a cleft palate in secondary palate. So always try to visualize palate like this. So this is the midbrain we are seeing. This is the nuchal translucency, and this is the IT we are seeing. I have measured the IT. NT you can measure. The machines have automatic measurements, or you can put the calipers on the most white part of the two lines. Then hand, we can see the digit. But what is the problem with this photograph? We are just seeing one hand, and if we move to the probe other way, we'll see the other hand. But how can we confirm the lady that both the hands and both the limbs are present together? It is always better to visualize the features in an actual plane with both the hands together. Medico-legally will be safe, and save this image. And it is always a good practice to split the image into two, showing stomach on this same side as the heart. So this will rule out heterotaxies. Then again split images for heart, two inflows, two outflows. And I'll show you. And in this image, you can appreciate 4 chambers of the heart, pulmonary veins entering into the left atrium and descending aorta. And by eyeballing only, we should see the axis of the heart, because if there is an obvious left axis deviation, there are chances of tetralogy of Fallot, hypoplastic left heart syndrome, or DORV is increased. So we are more cautious. We look for the outflow tracts, which can give us so many information, like this is the pulmonary vein, this is the aorta, and this is the SVC. So if we see only one vein, or if we see a reversal of flow in aortic arch, then it could be hypoplastic left heart syndrome. Then we see the retronasal triangle. We see this is though not a very good, very sharp image. We see the maxillary processes and the mandibular gap. If there is no mandibular gap, retrognathia could be there. Then always in a habit of measuring the biparietal diameter. And this is the axial plane showing brainstem and cisterna magna in axial plane. These are the two eyeballs with the lenses. This is the baby yawning. Today I was scanning. The baby just opened the mouth. You can see the upper lip and the lower lip, lower maxilla and the mandible. And try to see the spine also. I acquired a 3D image, and just see the spine in the 3D image. Great. This is not abnormal. This is fourth ventricle open. In first trimester, you will see this opening into the cisterna magna. And then always measure uterine artery Doppler as a risk assessment scoring. And if how do we say it is uterine artery only if the peak systolic velocity is more than 60. Here it is 119. There is no notching. We measure on both sides, and then we take the mean. And then don't stop the scan at this. Try to measure, see for the cervix, measure internal os to external os length for assessment of preterm labor. And these all the images I have taken transvaginally, because you cannot comment upon the fetal head. You won't get these kind of images with an abdominal scan. And if we find any abnormality, if we suspect any abnormality, then we go for a sagittal view of the head. which is easy in first trimester. We look for pericallosal arteries, and if Doppler we do if it is needed, not in all the cases. I hope I have been clear in my view, and thank you for patient hearing and giving me this opportunity to talk in front of such a august gathering. And I would love to answer if any question is there.
Thank you, Dr. Anju. I must congratulate you for the excellent presentations you have given to us and a very elaborate coverage of this subject. Every minute detail you have covered. As you said, the house is open. Audience are most welcome to ask any questions, not only from you, and to Dr. Nutan is also available. All questions will be answered by them. We have plenty of time and we can
Ananta,
take as
can
many
we
as
unmute
questions
Dr.
as-
Nanita, Dr. Poonam, and Dr. Nutan, please? We can steam them.
Am I audible now?
Yes.
Dr. Anju, yes, I totally agree with Dr. Seema ma'am that very, very good presentation. And I must say we have attended number of anti-scan webinars this season, but yours
Yes, agreed.
real totally information packed and lucid presentation. Congratulations for such a nice presentation.
Thank you so much.
And I can I start? Can I ask questions now, ma'am? Can we start?
Yeah,
with
yeah.
First of all, Dr. Anju, when if it's possible, I would like you to show the initial 2-3 photograph screens again. I think they are the real learning कहते हैं ना take home messages वाले जो
Which
हैं
one would you like to see?
the one the third or fourth of your
I'll just show.
yeah. Can you just start it from the beginning, 2-3 of them? I'll just
Okay, I'll start. Which one you want to see?
It's not displayed. First
Oh,
displayed.
share.
Yeah.
I think the screen is not shared, I think.
Yeah, now it's shared.
Okay. So which one you want to see?
Ma'am, I think it was the second or the third slide.
Nuchal translucency or the CRL?
The nuchal translucency one.
Okay. I'll just focus, you tell me. This one or this one?
The next one, ma'am.
This one?
Yeah.
Okay.
Yeah, the before one, ma'am, before one.
Yes.
Pehla wala, yeah. Ma'am, I should congratulate you on this. Very, very lucid and this is a self-explanatory picture. And I would ask all our members to see this. I think this, in a nutshell, this screen says everything regarding that. Ma'am, very beautiful picture, ma'am. This one.
Thank you. Thank you.
The next one also, ma'am.
This one.
Yeah.
And
This one only, ma'am. The other one. Yeah. Again, ma'am. Yeah. No, ma'am. The 75% wala.
Okay. This one.
Yeah. Again, ma'am. We have seen number of them, but these two pictures top them all because of their clarity. The this one and the other one. Really, ma'am, both of them you have taken pictures very beautifully, and they are both of them very, very clear. One thing I would like to ask, ma'am, do you ever need to do bimanual examination? Means
No.
TVS and TVS
No.
anytime, or you have
No.
always been able to manage on TVS only?
NT and CRL most of the time by abdominal examination. I do TVS for further detailing of head, like axial scans, then limbs also, then heart also. Like at 11, last scan I showed you, it was done at today, like did it today, 12 weeks. So all the whole anatomy I could see, but that too by TVS scan.
Yeah. So you routinely, when you first patient comes to you for NT scan, you are doing a transabdominal scan.
Exactly,
Yeah.
definitely. Once
Yeah.
first I do an abdominal scan, and then I finish it off with a transvaginal scan.
Right, ma'am. Right, ma'am. So this is what I wanted to highlight. Ki, we
Yeah.
can do our NT scan transabdominally, and if you want further detailing, we can go for TVS
And
scan.
actually, it is good, like cervix, commenting upon cervix internal loss by transvaginal is the recommended method. And it is the advantage to us if we are doing our scans, patient will never refuse for a transvaginal scan.
Ma'am, in your video, we couldn't see the cervical length measurement.
Actually,
Do
I
you have
missed.
that?
No, I took it. I missed to upload it. I did it
Yeah,
at
yeah,
around
yeah.
1 p.m. I missed it. I
Yeah.
measured it.
So, ma'am,
I,
can you just explain me measurement part, cervical, how to this entire
uh,
thing? You can just
Actually,
explain it.
and by endovaginal probe, once you are seeing the cervix, you focus onto the visualize the whole cervix in a sagittal plane, and we measure
Yeah,
the cervix length from internal os to the external os.
yeah.
And sometimes we can see that internal os funneling. I have seen a female lady. She came around like at 12 weeks. The internal os was totally closed. The length was normal. When then she came at 20 weeks, I could see the whole membranes bulging into the cervical canal, and only the external os tip was closed.
Okay.
Mm.
So, uh, did os tightening help in this patient?
No, I did it. I did that. Two patient, one patient it didn't help. She landed up in rupture and she aborted. The other lady, I did an emergency circulage at 27 weeks. She was eighth gravida with no live issue. And this time I just took a chance, giving her just 1% survival. But luckily she continued, and I did a cesarean section at 35 weeks, and she had a healthy baby.
I think, ma'am, you can stop the screen sharing so everyone can
Okay.
have a. Anyone else who would like to ask a question? Yeah. Can we unmute others also? Priyanka, Anand?
Ma'am, Khushbu here, yes.
Can we unmute others?
Ma'am, I cannot hear you. Yes?
I am asking that others, do they put their question in the chat box or will unmute them?
No, actually, ma'am, yeah, that's what I was saying. There are no questions yet we have received from in the chat box, ma'am. Dr. Poonam has dropped a message in the chat box that they can ask questions, but I don't know. There has not been any questions.
Okay.
Can we wait for 3 minutes for them to post the questions if they want?
Yeah. Till that time, I think.
So, doctor. Yes, so doctors, if you have any questions, we give you 3 to 4 minutes. Please put your questions in the chat box so that the speakers and the chairperson, secretary, moderator can answer the questions.
I think, Priyanka, there was some connection issue also. Lots of people were having difficulty in joining. Isn't it, Nanita?
Yes, yes, Dr. Indra Bhargav, Aishwarya, they can't join and they message me. Somehow there is problem in the link or whatever the reason.
Anyway, I think
they couldn't join through the audience link, huh?
Yeah.
The link which we have shared in the invitation card, they couldn't join through that.
Yeah, that is what they say.
Okay.
Dr. Anju, can you please can we continue with the conversation? I think you were anything else that
You
is
please,
important?
whatever you feel like, you please ask me.
Yeah.
I must congratulate you. Your presentation was really good. And like, first of all, prevention is always better than cure. If we do all the prevention, we might not land up with these problems.
Yeah, but I think still anti-scan for us obstetricians, we are still in the learning curve of the
We
anti-scan.
have one question here.
Yeah.
Yeah. So Dr. Aishwarya Sharma is asking, very common to find echogenic foci in heart at 12 to 13 weeks. Any significance or we can ignore it?
Single echogenic focus in first has no significance, and it is to be understood like echogenic focus is a soft marker for Down syndrome in second trimester, and that too more than one. And then we have to calculate the a priori risk of the patient. If it is more, then we give a significance to this. Otherwise, single echogenic focus has no significance.
Dr. Anju, I have heard that there is now a panel for evaluating the anti-scan. If you are doing anti-scan, you need
Yes.
to get yourself accredited. Can you tell us
Yeah,
more about that? Yeah, can you tell
I
us more
have
about
accredited
that?
myself with FMF. You
Yeah,
can go on the FMF site and
yeah,
you need to upload your images. There is a lecture. You have to attend that online lecture, which is already recorded. Then you upload your images, and if they are according to their norms, then they approve it, and you are given as an FMF accreditation.
okay. And what advice would you give to the beginners? Because when initially we are doing anti-scan, getting that vertical, horizontal pick is the biggest challenge.
It is
Uh,
not a problem. It is,
uh,
first of all, just remove from your head that it is a problem. Even
yeah,
I was a beginner sometimes back. Just do
yeah,
it, do it, do it.
yeah. So that is what
If
exactly.
radiologists can do it, why can't we do it?
Yeah,
We
surely,
have
surely.
more brains than them. We should try it.
uh, and obviously we have the advantage of the clinical background of the patient that always helps us.
Exactly.
That helps us in diagnosing these things. Why I am discussing this, that yes, anti-scan now is from the books, it has come to our consultation tables. That is, now we are
Yes.
actually doing it. Up till now, we were just learners in that field, trying to learn, trying to understand the significance. But slowly, anti-scan at 11 to 13 plus 6 weeks is going to become the norm, and we may have to schedule our all. We may have to means we are actually scheduling all our visits accordingly, and that is how the patients have to be counseled.
I know, and
Yeah,
I would always tell that please don't stop at NT. Try to look the features as a whole in all the views, because we might measure the NT. It might be an acrania, we are missing out on that. How will we
yeah,
save ourselves as a medical legal in court, law of court? So we have to update our knowledge.
yeah. So I think it's what better way to start at your own home ground, because we are a small group here. It's always easier to learn and assimilate and discuss, because in
Actually, yes.
yeah, in bigger webinars it's very difficult to gather that because it's so I think it's always a good thing to learn in your own home ground.
I
Uh,
know.
yeah,
And
Dr.
use a
Poonam.
good machine.
Yeah,
Initially, used to like have trouble. Like you should have a good machine, then only you can see. Because if you struggle focusing the organ, focusing it, and we just trying to imagine things, that's not a good thing.
yeah, that's right. So I think yes, it's good that now we have a new, I think, learning modality that has become part and parcel of our practice. Earlier, ultrasound was something that has to be done. Maybe it just major things have to be seen, and that's enough. So, Malab, I think we are better able to correlate with the anatomy and them. Dr. Poonam, would you
Yeah.
like to add anything? Yeah.
Um, I think that has very much put everything very comprehensively. I
Uh,
can't think of anything else to ask. Except which machine do you have, Dr. Anju?
I
Ultrasound
am using Voluson E8 Radiance.
Okay.
Yeah, I totally agree that the better the machine, better you are able to see. And in NT scan, there is a lot of things which are helping us out in the easy measurement of the NT. You just have to focus it, and many times you are able to measure it out nicely.
Yeah.
So, Seema ma'am, anything else that you would like to add?
No, nothing. But this is the era of internet. Our patients go on searching on internet. There's a vast knowledge spread over there, and we should be ready to answer any and every questions which they and their relatives ask. So we must keep on updating ourselves. And this one was a very good talk from your side.
Actually, practice makes perfect, and we have to keep on doing and making ourselves perfect. But the thing is that it's such a vast subject, no, obs and gynae. You can't do everything together. You do OPD, you do surgeries, you do emergency.
Actually, what happens is when
it's very difficult to spend more dedicated time on ultrasound. So we sometimes relegated to the radiologist. Yeah, tumhi kar lo. Like that.
It's difficult to do it.
Yeah, we have our hands full. As obstetricians, we always have our hands full. Though you are on duty 24/7.
But like I always like to do NT myself because I trust myself, and later on maybe if I am busy I can ask the radiologist to do it. But even if I ask the radiologist to do an NT, I would always like to see myself.
That's good. That's good.
That's good. Just to be.
I think can we? Nanita, if Aishwarya is not able to join, can
Aishwarya is not. Yes, she is there.
Can you ask her to join us as video?
Hello.
Yeah.
Hello, Dr. Nutan.
Yeah.
Kindly add Dr. Aishwarya.
Yeah, I think, ma'am, there is. What, ma'am? What do you want to do?
Dr. Aishwarya Sharma, can you just add her also, her video? She has to give vote of thanks.
Oh. Dr. Aishwarya Sharma?
Yes.
Ma'am, Ananta, can we do it? Because she has joined through audience link, I guess, right?
She just asked the question. She must be.
She's in the audience.
Yeah. She's here. Yeah.
Okay, just can you add her?
Yeah, send her ma'am request.
So meanwhile, ma'am, just we should acknowledge the people who have thanked us. So Dr. Shweta Agarwal said it is a very informative talk. And Dr. Indira Bhargava, she said that she could join a bit late, but enjoyed and had a wonderful. Both the talks were very wonderful.
Dr. Anju, I would just like to add that in our society we have lots of associate members also, and number of them are radiologists. And luckily, they always join in any of these webinars related to NT scan or anomaly scan or anything related to radiology. And they have always been very actively involved in our society. And it's a very nice learning experience that we enjoy with them. We have Dr. Aishwarya here. Dr. Aishwarya,
she's here, ma'am. Yes, Dr. Aishwarya, we can hear you.
I think she was having trouble joining us earlier. Dr. Aishwarya, can you please thank Dr. Anju for her beautiful presentation?
Yeah. Okay. You all can hear me?
Yes, sure.
Yes.
So on the behalf, it's for Dr. Anju ma'am. On behalf of talk, I would like to extend my thanks for such illuminating talk. I thoroughly enjoyed it. And in today's time where the medical legal implications are so high, it's very much important to detect the things at earliest. Doing NT by ourselves, I think it's a need of ours. We should do it, and continuous learning and the way you have explained, you have encouraged us so that we can continue our doing education by ourselves. Thank you so much, ma'am. I would also like to thank Dr. Nutan and our chairperson, Dr. Seema ma'am, Dr. Poonam Mukhija, our dear secretary, Dr. Nanita, for organizing such a wonderful talk. And words are falling short for to explain such beautiful Zoom meeting today. Okay, so over to you, Dr. Nanita.
I'll
Thank you,
just
Anju
ask.
madam. Yeah, your talk was so informative and it will help us. Thank you for being with us and giving us such a nice talk.
Thank you.
Nutan ma'am.
Yeah, Dr. Anju, can I ask one more question?
Yeah,
Uh,
please.
uh, when we are reporting anti-scan, is there any specific number of photographs that we should add on pics of the ultrasound pics that a
No,
minimum
no,
that is required, the
no,
other
no.
than the longitudinal view that we take and the 75% magnification that we take? Anything else that is mandatory that it should be there in our report?
No, no. It's the only ideal mid-sagittal view, ideal magnification, and correct placement of the calipers for
Okay.
entry.
That will be enough because
Yeah.
our reports go for dual marker in along with our ultrasound
For
report.
dual marker, no, for
Yeah,
dual marker, you need to give the CRL also because
yeah,
they take in account for CRL. But please get all dual markers at a good platform. Not all labs are doing that.
yeah,
So, and they should give the reporting as the risk factors like low risk, high risk, or intermediate risk, and we should evaluate it accordingly. If the if it is low risk less, if it is less than 1 in 1,000, then we can at least assure the couple, though not 100%. If it is less than 1 in 250, then it's an high risk. Then she should be advised NIPS or invasive according to the history. Or if it is an intermediate risk, then again we should advise our NIPS to be on a safer side.
right. So I think this was one point that I had forgotten to mention. So I think this completes the entire thing that dual marker and care. I think it's time to say bye. Um, Thanks, Dr. Anju. Hoping to connect to you soon, very soon, because I think these webinars are going to continue.
Sure, I thoroughly enjoyed being with you, and it had been a pleasure to
Uh,
be with you. I met Dr. Poonam yesterday. It had been a pleasure to meet
uh,
Dr. Poonam, you, Dr. Nutan, Dr. Sivan, Dr. Nanita, and Dr. Aishwarya. And happy quarantine to Dr. Poonam. You come
Yeah.
out of this quarantine soon.
Yeah. Tomorrow I will have my COVID test done.
Okay, no, you'll be fine. It will be negative.
you are
I
looking
would
pale
wish
and
for
hearty
that.
to us to just
Yes.
be. You are looking all pink and glowing and healthy, so don't worry. Your reports are going to come fine.
Yeah.
Yeah.
Yeah, I
Okay.
will be.
Bye bye to everyone.
And thanks to the whole society for inviting me for this talk. And I would love to come again
Yeah,
anytime.
yeah. We'll surely
Thank
connect.
you. Thank you,
Thank
ma'am.
A
Thank
special
you.
thank you to the Acumentis people, Khushbu, Priyanka, Vineet, and Ananta, and all of you. You have been very, very cooperative. You have been patiently guided us because all of us are not so net savvy, but you have been real. Uh, you you have had our back. So thank you for being with us. Okay. Have
Thank
a
you so
great.
Okay.
much, ma'am.
Thank
Thanks a
you.
lot
Bye.
for
Bye.
being on board.
Bye.
Thanks to all.
Bye.
Bye. Bye.
Bye,
Bye bye.
ma'am.
Take care.
Bye.
Bye. Bye.
Bye-bye.
Bye.
Bye.
Nanita, अब हम